All right, today we are diving into gastric varices. This is an absolutely critical topic for anyone working on the GI or internal medicine wards. Now, you might think of these as just another type of esophageal varix, but that's a mistake. These are a totally distinct, high-stakes condition, and really knowing how to manage them can make all the difference for your patients.
We spend a lot of time learning about esophageal varices, but their gastric cousins, they're a completely different animal. They might be less common, but when a gastric varix bleeds, it's often way more severe and, as you can see, carries a much higher mortality. So let's just get this straight from the jump. This is a more dangerous bleed.
So here's our game plan for this explainer. We're going to follow the path you take with the patient. We'll start with the basic anatomy and what causes these things, then walk through the clinical workup, get into the really complex treatment strategies, and wrap up with teamwork and outcomes. Let's dive in.
Okay, first things first, anatomy and etiology. If you're going to manage these bleeds effectively, you absolutely have to understand the what and the why behind them. It really all comes down to the underlying plumbing. So what exactly are we talking about here? Well, put simply, gastric varices are these big, dilated collateral veins in the stomach lining. They pop up because of portal hypertension, and while you'll see them in about 20% of patients with cirrhosis, which is less often than esophageal varices, we already know they're the ones to be really worried about. Now, how we classify them is actually super important for treatment. The system you have to know is the Sarin classification. It basically divides them up based on where they are in the stomach and the relationship to esophageal varices. You can see GOV1, which are basically esophageal varices that extend down into the stomach, are by far the most common, making up about 75% of cases. But as we're going to see in a bit, it's the GOV2 and IGV1 types that really keep clinicians up at night. And that leads us to the million-dollar question. What is actually causing this dangerous backup of pressure in the first place? This slide lays out the cascade perfectly. It all starts with increased resistance to blood flow inside the liver, usually from something like cirrhosis. This makes the pressure gradient, what we call the HVPG, start to climb. Once that gradient hits 10 millimeters of mercury or more, boom, you've got clinically significant portal hypertension. The body, trying to fix this, creates these bypass routes, or shunts, to relieve the pressure. And it's shunts like the gastrorenal shunt that are key players in forming gastric varices. The causes pretty much fall into two main buckets. On one side, you've got your classic cirrhotic causes: alcohol, viral hepatitis, and of course, the ever-growing problem of NASH. But, and this is super important, you can't forget about the non-cirrhotic causes. Things like a blood clot in the portal or splenic vein can cause what's called segmental portal hypertension, which can lead to these nasty isolated gastric varices, even in someone with a healthy liver. All right, now that we've got the basic science down, let's get practical and talk about the clinical investigation. How do you go from just a suspicion to a real diagnosis when you're on the wards? So when a patient comes in, you're basically a detective looking for clues. In their history, you're listening for things like hematemesis, vomiting blood, or melena, plus any signs of liver decompensation. And on your physical exam, you're hunting for those classic signs of chronic liver disease: yellow eyes, a fluid-filled belly, a big spleen, the whole shebang. But here's a really interesting clinical pearl. It's almost a paradox. Unlike their esophageal cousins, gastric varices often don't show up with a bleed. A lot of the time, they're just found by chance during a screening endoscopy. The takeaway here is that while they might bleed less often, when they do decide to go, it is an absolute catastrophe. So which ones are the real troublemakers? The evidence is crystal clear. It's the GOV2 and IGV1 types. These are the ones located up in the gastric fundus, and they are notorious for bleeding more often and carrying the worst prognosis. These are the ones you absolutely have to respect. And that brings us right to the heart of it all: treatment. Let's break down how to manage these, from the acute bleed to preventing it from ever happening again. Okay, your patient is actively bleeding from a suspected gastric varix. This is an all-hands-on-deck emergency. The protocol is straightforward. Step 1, get them to the ICU. You've got to resuscitate, but be careful. The target hemoglobin is right around 8. Then you correct any clotting problems, start broad-spectrum antibiotics, and get them on a vasoactive drip like octreotide. And the final, most critical step is an urgent call to GI for an upper endoscopy, like now. So once the endoscope is down, what's the plan? Well, for those really high-risk GOV2 or IGV1 varices, it's an endoscopic showdown. And the clear winner is something called GVO, which is injecting cyanoacrylate glue, basically medical-grade superglue, directly into the varix. The data shows that compared to regular banding, glue injection is way better at stopping active bleeding and preventing rebleeding. It's the go-to for these specific varices. But what if the bleeding is just too heavy for the endoscopist to handle? Or what if the glue just doesn't do the trick? What's next? This is where you get your interventional radiology colleagues involved because they have two amazing procedures, TIPS and BRTO. A TIPS procedure creates a new path for blood flow inside the liver to lower the overall pressure system-wide. BRTO, on the other hand, is much more targeted. They actually go in backward through that gastrorenal shunt we talked about and just obliterate the varix directly. BRTO is a fantastic option, especially for patients who already have hepatic encephalopathy because it doesn't make it worse like a TIPS sometimes can. Okay, so you've controlled the acute bleed. Great. Now the job is to make sure it never happens again. The strategy here is totally dependent on the type of varix. For the more common GOV1 type, you can often use a familiar playbook, non-selective beta blockers plus endoscopic therapy. But for those high-risk GOV2 and IGV1 varices, you have to be more aggressive. The guidelines say you should move straight to either TIPS or BRTO as your first-line therapy to prevent a rebleed.
So for our final section, let's zoom out a little and talk about teamwork and outcomes. Because honestly, it really does take a village to manage one of these complex cases. And this slide just shows you how big that village is. It is not just the GI doc. You need the hepatologist managing the liver disease, the intensivist in the ICU, the interventional radiologist for the TIPS or BRTO, not to mention your amazing critical care nurses, pharmacists, and the blood bank team. Clear communication between every single one of these people is absolutely essential for a good outcome. And just how good can those outcomes be with the right team and the right tools? Well, check out this number, 97.3%. That's the clinical success rate for BRTO found in a huge meta-analysis. It's just an incredible testament to how effective these modern, targeted interventions really are. But at the end of the day, we have to remember the most crucial point. The long-term prognosis for these patients isn't really about the varix itself. It all comes down to the severity of their underlying liver disease. That's why we use scores like the MELD or Child-Pugh. They give us the best picture of a patient's overall risk and what their future might hold. So let's end with a final thought to chew on. We've seen how good glue is, and we've seen the incredible success of BRTO. The future might be in combining these ideas. Using endoscopic ultrasound, or EUS, allows for unbelievably precise therapy. So the big question is, will EUS-guided combination therapy, using both coils and glue at the same time, become the new gold standard for both stopping acute bleeds and preventing them from ever starting? It's a really exciting question that just shows how fast this field is moving.